Hello, I'm Dr. Jonathan Levine, host of Case Bites, where we unravel the complexities in dentistry from simple to complex cases from a treatment planning case presentation standpoint. Let's get started. Tonight, we have Stanislava Misci, who is a prosthodontist. She teaches in the prosthodontic department at Boston University Goldman School, a colleague and friend. Excited to have her to present to you. And remember, at Case Bites, our panel of experts are presenting these cases, but soon, our dentists out there who are listening to these Case Bite webinars are going to be invited to present their cases so that we can all learn from each other. And that's what it's all about. The collaboration and the energy that collaboration brings, where we're sharing ideas and everybody brings their superpowers to the table and their capabilities so that we can benefit the lives of our patients. Dr. Misci, take it away. We are so excited to have you here.
Thank you very much, Dr. Levine, for the kind introduction. It is absolutely my pleasure to be part of this team and be able to share some of my thoughts and my work with my colleagues. Everybody that's watching those presentations, welcome. The case that I would like to share with you today, I decided to name Envisioning the Case. And the reason for that is because I feel the most creative part of our treatment goes into determining the future tooth position, determining and envisioning the future clinical crown position. Once we have that, from that point on, I feel the case is done. Once we have that, the rest of the steps are mostly technical. So the patient I would like to share today is a female, middle-aged. Her chief complaint is, I do not like my smile and I cannot eat harder foods. As you can see from her smile, she has a number of missing teeth. She has excessive maxillary display. And when asked what kind of visual image she imagines, she prefers the clean, healthy, natural. In terms of medical history, she does not have anything significant, no contraindication for dental treatment, so we're good to go. Radiographic evaluation, we can see on her panoramic radiograph, we have a number of missing teeth. On the maxilla, we only have 6 remaining teeth. It's not very clear from the panoramic, but I can share from the clinical examination and the FMX, which I do not have on those slides, that the only really compromised tooth on the maxilla is number 13. It has a periapical lesion. The position is really unfavorable, has a carious lesion, quite extensive. And the other hopeless tooth is number 20 on the mandible. Other than that, the rest of the teeth are in a pretty restorable condition. CBCT was done later at the prototype phase, so the images will be shown later. Based on the evaluation of the patient's smile, we have transferred a few parameters on the models, on the mounted models. These were mounted with a Facebook and in CR. This case is about 15 years old, so we did not have all the digital technology available at the time. We had some. Now, we can appreciate marked on this model the patient's upper lip line. You can see it's about 5 millimeters from the gingival margin of number 8. And also we can see the lower lip line at smile marked on the incisal edges with the pencil. In terms of periodontal charting, not too significant findings. We can appreciate some bone loss. We can see that crown to root ratio on the maxilla is mostly in the 1:1. We can see we have short roots on the maxillary anterior teeth, except for the canine. Probings are 1 to 3 everywhere, except for, as I already mentioned, number 13 is compromised. In regards to aesthetic evaluation, we go through Dr. Levine's forms, and we can see that the patient's chief concern is the gum showing. She would like to correct that, and she's looking for clean, healthy, natural smile. She admits it's a result of years of neglect. There is nothing abrupt. There was no trauma or any other acute change that caused this condition for her. Facial analysis, we can look at through all the parameters, but basically we have a smile that is a little bit canted. A midline is pretty good. It is canted, however, coincides with the midline of the face. Maxillary displays about 4 millimeters, 3 to 4 millimeters, but the incisal edge is not visible. Mandibular displays about 2 to 3 millimeters of the incisal edges. I do not have the profile pictures here, but we have a normal profile within normal shape. And we can look at her smile picture and her repose picture. We can look at the tooth display on both. Continue with the dentofacial analysis. The patient is definitely a high smile line. Her incisal edges to the lower lip relationship is convex. The maxillary anterior teeth incisal edges are covered by the lower lip. As I mentioned, the midline coincides with the midline of the face, however, is slightly skewed to the right. And her bilateral negative spaces are increased. However, she does show the first premolar, which tells us that she potentially can show more than 12 teeth. Her teeth are short and square looking. Her central incisor is about 8 millimeters wide, the lateral 5, and the cuspid about 6. And when we look at all of those aesthetic parameters, we can see that the check marks are all on no, which tells us that we pretty much have to change everything for this patient. And our proposed maxillary central incisor length is within the mean, 10.5 millimeters, and we're looking to bring that gingival margin about 4 to 5 millimeters apical. Now, with this kind of cases where all the aesthetic parameters are off, I'm looking at that patient as a complete denture patient. How would I determine the tooth position is the same way we were taught in dental school to determine the tooth position for dentures. So I have to determine these 4 parameters. I have to decide where would my maxillary incisal edge be, where my mandibular incisal edge be. I have to decide on my vertical dimension, and then I have to record my CR. Once I have those 4, I feel I can position the rest of the teeth. Again, 4 very important pictures here. We know certain parameters from literature. So we know that the mean length of maxillary central incisor is about 10.5 to 11 millimeters. We know that the mean maxillary incisor display at rest for this patient's age group, which is in the 50s, is about 1.5 millimeters. Mean mandibular incisor display at rest about 2.5 millimeters. So now looking at these views, I can see that from my gingival margin of number 9 to her upper lip at smile, it's about 4 to 5 millimeters. I am also looking at the tooth display at rest, which is about 3 to 4 millimeters. We already said that mean maxillary incisal display at rest at her age should be about 1.5 millimeters, which is basically cutting this box of 3 millimeters in half. So if this is where my maxillary incisal edge should be, how do I relate this to the rest of the pictures and to my evaluation? So as we said, this box of tooth display does not include the incisal edge. She's already covering the incisal edge with her lower lip. So basically that box transforms somewhere in the middle of the tooth. So having that box cut in half means that we have to bring this incisal edge to about this level here, the middle of the box, which is the middle of the tooth. Now, bringing that back to our first picture where we have a 5 millimeter from the gingiva to the gingival, from the lip to the gingival margin, and then the total length of my central incisor for her is about 10 millimeter, and we already said we're going to cut it in half for our ideal proposed incisal edge position. That means that we have to go another 5 millimeters here. So that would give us 10 millimeters, and an average 10.5 for incisal edge means that we have an extra half a millimeter to play with, which we'll probably tuck in under the lip. That brings us to digital smile design and how we're envisioning her anterior teeth positions about this way on the pictures. So we can see how much of tissue we need to cover, how much we need to move those teeth. Again, we're talking about complete denture concept to get to that point. And when we have teeth in place, it's a little bit more difficult because we cannot just put occlusal rims and set up some denture teeth. So we have to go through the process of measuring and looking what landmarks we have in the mouth, as bad as they are in terms of position, but just to determine where we want those incisal edges to go. And just to review how we determine the incisal edge position, the multiple factors involved, how we determine the vertical dimension, again, the multiple factors involved, and then we have to record the face bow and the CR record. And I just want to point out something about phonetics. We do know that these are very important parameters when we decide on incisal edge position. However, they're just one of the parameters that we're looking at. We know that even edentulous patients can pronounce a very nice F and S sounds. So that guides us to where we want that future incisal edge to be. But for patients that are already with teeth that are misaligned, not in ideal position, we see clearly that this tooth is not where it's supposed to be. They're still able to pronounce an F and S pretty good because those changes occurred over a long period of time, so the muscles adapted to the available space and lip and musculature. So anyways, we keep going with the case, and based on our aesthetic evaluation and all those lines that I was drawing, we determined that this is our diagnostic waxup. This is the tooth position that we would like to have for this patient. Now, based on the tooth position, we've created a plan which included to extract the remaining maxillary teeth and give her an immediate denture at that point, which is the tooth position on that immediate denture is based on that waxup. Of course, to stabilize the occlusion, to give her more relief posteriorly, we also fabricated an interim mandibular partial denture. The next step would be patient is interested in having a fixed restoration, so the denture is just an interim step. However, we're looking at an implant-supported fixed restorations for the full dentition. Now, understanding that patient had quite a bit of bone, excess bone, which is, we love to see that for our implant cases, but the bone is not necessarily where we want it to be. Even though she had quite a bit of bone height, that bone is something that we need to reduce because actually the future crowns need to go even higher, more apically. So based on that ideal waxup that we made, we fabricate a guide for the sinus lift procedure. And we like to do the sinus lift based on guides. Sometimes that might sound like an overkill, but for this kind of cases, we already have in this vacuum shell, on this guide, we have the gingival margin of our desired future tooth position, which I mentioned before, to me is the most important part of the treatment. So once I have that margin, now we are working with known parameters. So we know that from that future desired gingival margin, our implant will have to go about 3 millimeters deeper than that. Then we know that the implant in that area would probably be about 10 millimeters. If we can get longer, great, but hardly in that area. We're already doing a sinus lift. So if I have to plan for a 10 millimeter implant length, 3 millimeters from the gingival margin, that's we're up to 13 now, so an extra couple of millimeters for the sinus lift. So we can basically plan the depth of the sinus lift according to our future implant position and our future gingival margin for the future restoration. Now, the other component is also how far posteriorly we're going to go with the sinus lift. So again, having that guide is very helpful for our surgeons, and they appreciate that. Moving on, for the mandible, we're looking at anterior teeth with some spacing, and also we said that we would ideally like them to be about 1 millimeter intruded. So we went to some alignment of these teeth, and this is what we were able to achieve very conservatively. She didn't want to go through any extensive orthodontic treatment. And at this point, we are able to try our prototype, our waxup. And nowadays we do those waxups digitally, and we print them and we can try them in the patient's mouth. At the time, this was a waxup. So we have that desired future crown position, desired gingival margin position, desired video, and everything is tested at that point. We're planning for 6 to 8 implants on the maxilla with a fixed restoration, and on the mandible, 2 implants on each side with 2 implant bridges. And we can pause here for a moment and hear everybody's thoughts.
Dr. Misci, thank you so much for showing this case, and especially that the case was done how long ago? Did you say 15 years ago?
We started it about 15 years ago and finished it probably 12.
Yeah, which was a lot before a lot of the implant guided, with a digital workflow, the implant guides. And it really, it's such a great case to show kind of our evolution with guides and with our digital workflow, and linking up today our CBCTs with exactly where we want tooth position. And,
this was actually our first guided case.
Yeah, fantastic. Fantastic. Well, let's open it up to our roundtable of experts, periodontists and orthodontists, Dr. Robley and Dr. Kim, Dr. Jerem on the restorative side. Let's open it up to some questions, and then we can take it from there.
I had just had one particular question that I'd like to know for myself. When we do lateral window sinus lifts, they're not a really difficult procedure to do, but typically they can lead to some more swelling. So what were the instructions that patients had with regard to wearing a denture, not wearing a denture while that patient was healing?
Thank you very much, Dr. Kim, for the question. So I actually have slides when I'm presenting this case more extensively on that step, but of course we're limited to the number of slides and timing on the presentation, because we want to make this keep this short and sweet. So to answer your question, the patient had that immediate denture which she wore for some time, and of course we go through a number of relines with tissue conditioning and soft liners during the process of healing. Once she had the sinus lift, basically just bilaterally, that denture was relieved completely because the sinus lift was done bilaterally, and only in those areas we relined with a tissue conditioner. So during that initial healing, she still has the denture. I know ideally we would like her not to put any pressure on any of those sides, but the reality is the patient needs to wear something. So she would have the denture and just in those areas completely relieved and tissue conditioning.
When this case was done and you were doing this as the first guided case, what have you taken away from, guided surgery that you put forth in cases after this one? What were some of the benefits to the guided workflow?
Well, we can't really get enough of guided surgery and digital planning, do we? Of course, we implement it now for every case. It's such a freedom to be able to plan so predictably our implant positions nowadays with this technology. So this is why even today, when I work on a case, I feel as soon as I determine the tooth position, I'm done with the case, because from there it's just a matter of millimeters and parameters that we know we have to follow, and just the whole team working together. Of course, it's a lot of work, it's a lot of procedures, it takes a lot of technical skills, but it goes very predictably.
I love that. Because you're in essence, you're trying to work in reverse. When you say that once you know where you need those tooth, or you need that tooth position, everything else from there falls in line. So it's like your key, it's your legend, and then from there you can kind of develop everything very predictably. I love that.
Exactly. Thank you. Any other questions at this point, or I can move on to the next slides?
I was curious, when you're working on these cases with your surgeons, are you there together on these bigger cases?
I do. Yes, I know it's not as profitable, but it's more predictable. And also I learn a lot from the surgeons, and I feel my surgeons are the best prosthodontists, and I'm the best surgeon by doing that among prosthodontists and among my small group.
Wonderful. We definitely appreciate it when we have our restorative dentists or prosthodontists around for the surgery, just because, I mean, when we need that guidance, or for whatever reason things aren't going exactly the way we like it to go, you got to have a plan B. And I would love to make sure that that plan B is acceptable for my restorative dentist.
Yeah.
Should we just proceed to see what you did?
Yes, so I can continue. Basically, what I did is very similar to what I presented as a plan. The unexpected piece of the puzzle was that the patient left for about a year. She went through some severe weight loss program, which wasn't health related, just something elective. And when she came back, she had the denture. However, her whole face had changed. Her bone levels, her tissue thickness, everything had changed. So we had to do one more wax up, a full mouth, to evaluate now with what we had, how we would proceed, if we would keep it as a fixed case, or she would need a flange for a denture. So again, we start as a complete denture procedure. We make our wax rims, we mark our midlines, we mark our smile lines, incisal edge positions, and did the wax up. Then we tried the wax up, our prototype, and even though she doesn't have the same puffiness in her lower face, she still looked acceptable, and she chose to go with a fixed treatment versus a treatment with flanges, which will give her more prominence of the lips and a little bit more fullness. So this is the prototype, the wax up tried in the mouth, and the patient approved that. So we can move on to the next step, which is the surgery planning. So we basically duplicated that prototype into a radiographic guide. And we can see on the CT scan some of the images, but most important image to me is this view here, where we can see the tooth and we can see the cervical portion of the tooth. So this is my desired gingival margin after the restorations are inserted. So we plan the implant position about 3 millimeters from there, and that would allow us to have that future crown height at that level, even though we might have bone there right now, but we can plan for that future crown length and that future gingival margin based on our implant position. If we have to reduce bone in the process, we reduce bone in the process. But what we try to avoid is to put the implant to the bone level, ignoring where our future margin will be. As we saw in this case, the patient had so much extra bone everywhere. So if we had just placed the implant to the bone level, she would end up with a very compromised treatment. Basically, we didn't change anything, just gave her more crowns. So having that planned, evaluated, and considered, that future gingival margin just allows us to place the implant, calculate the placement of the implant to the proper depth from where we can go with whatever procedures are necessary later on to make sure that we have that crown height. So the guided surgery, nowadays everybody's familiar with the process of how it's done. I just included a few images of that and the transition of the restoration. And these are just the provisionals for this patient. This is probably a couple of weeks after the guided surgery. We delivered the same day. I just didn't include all the images chronologically. So this is the temporaries for the mandibular restorations and the maxillary, all provisionals. Any more questions at this point?
So if you were doing a similar case today, would you change based off materials or some of the different aspects of guided surgery? What would you possibly do different today?
Yes, a very good question. Thank you, Dr. Jerome. So again, the most important part of the treatment is determining the tooth position. We can use different technologies, whatever we have available to get there. Nowadays, we do most of the planning digitally, and then we either mill or print a prototype, which we evaluate. The most important question for this kind of fully edentulous arches is whether we're planning to have restorations that don't include any gingival restorative part, no pink porcelain, so-called pink porcelain, or restorations that will have pink porcelain. And that is a very important piece of the puzzle, because if you're going to have a pink porcelain, we all know that that transition between pink porcelain and gingival is almost impossible to hide. So we have to tuck that in beyond the smile line. So that will be the only difference, that if we're planning a case that will have pink porcelain, we would go through some stages where we will evaluate how far more apically we need to place those implants, because now we're not guided by the future gingival margin of the restorations, we're guided now by our lip position. So that, in many cases now, I am actually more inclined to do rather than this. This was a unique case where the patient had so much excess of bone that it was easy to go to just crown level without pink porcelain. But for the majority of the cases out there, we are lacking bone. So we are going to put some pink porcelain for the most part. And if we're going in that direction, the worst is to end up a case with pink porcelain and the patient smiles, and then you can see the gum and you can see that transition. So we definitely want to tuck this away. And those kind of cases are actually very predictable, because the pink porcelain will not recede. So the aesthetics of the case will be preserved over time. And the other thing going for us is that the lip actually lengthens with time. So if anything, if the patient is not showing that transition today, the chances are they're going to not show it even more in the future. So this, in a way, works really good for us and for the patient, obviously.
Dr. Misci, this is a beautiful case, but I had a question here. This is a periodontist dream to have too much bone or excess bone here. And it looks like, based on previous slide, this guided surgery was done flapless, right?
I'm sorry, flapless, yes.
Yeah, so I was wondering why it was done that way, just because, again, when you have a case with such excess bone, just as a periodontist here, my concern would be is just the way the soft tissue is relative to the teeth. Maybe some more food entrapment or difficulty in cleansability. if it was a guided surgery with an open approach or with a flap, and then maybe we could ramp that bone. I just would love to know your thoughts on that.
Yes, that's a great question, because we do have these cases where we have to open up the flap and we have to reduce the bone. So yes, definitely gives a lot more visual and predictability. In this case where we had the excess bone, but at the same time we could see from the CT scan that we don't really need to reduce bone. Our measurement from the desired gingival level, future gingival level, was about at the level of the bones. So at that point, there was no need to open the flap. As we know, it's a lot easier healing, a lot less swelling, much easier recovery for the patient when flaps are not elevated. However, I'm not a periodontist or a surgeon, so I don't want to sound like one here, and I go only by what my team recommends.
Dr. Misci, just to comment and maybe to bring it home, you know, this clinical case that you showed from 13, 14 years ago, it reminds me of the expression that the digital workflow won't make you a great dentist. And what is so interesting here is that the fundamentals of understanding smile line, incisal edge position, ideal central incisor tooth length, realizing and doing all that pre-planning that you did to determine where is the gingival margin and where is the incisal edge and what is the ideal tooth length. And we believe this since we first developed that aesthetic evaluation form 20 plus years ago. That really stands out in my mind to give this great result where we have, you know, the emergence of these teeth right out of the soft tissue in an ideal way that it looks incredibly natural. So all of that fundamentals of aesthetics still holds today. And what digital dentistry allows us to do, as we know, is to plan at a better level, but really to communicate better interdisciplinary amongst our colleagues, amongst our surgical colleagues, our technical team, our periodontist, orthodontist, oral surgeon. So it's very exciting because of the digital workflow, but the fundamentals, like in sports, is what's going to win the day, to understand those fundamentals of aesthetic.
I'm so glad you brought this up, Dr. Levine, because I can't agree more. The fundamentals of dentistry are the same. It's just the tools are different. And the tools will continue to change and make our lives easier, hopefully. But without the basic knowledge and understandings that we're trying to promote, the tools we can't use properly.
Yeah. Well, and knowing my colleagues at Boston University in the prosthodontic department, between you and Dr. Alexander Bendayan, I know you spend your days teaching and showing the postgrads the fundamentals and the importance of it, in addition to the new workflow and our new technology. And that's what makes things so exciting. Well, just to bring it home, thank you so much for showing this case. It was such a perfect case to really show kind of the beautiful thinking that went into implant-guided dentistry from 15 years ago. And today we know that it's even gone beyond this because of our new CBCT, our cone beam, and our implant-guided positioning, and really making things even more predictable. So thank you for bringing this for us, and thank you to our specialty team for participating. And we're excited to keep bringing case bites to our dental professionals. Thank you, everybody. Thank you for joining us for Case Bites. If you haven't already, please subscribe to this series to receive a new case in your inbox every week.